But hello, thank you all so much for joining us today for Trauma-Informed Care in Reproductive and Sexual Health. I am so excited to be speaking with you today on this topic that I'm really passionate about. Appreciate you taking the time to join me and HCT as we delve into this. So again, a little bit of housekeeping first. This webinar does have closed captions available. To enable them on your screen, just click Live Transcript at the bottom of the screen and then click Show Subtitle. And you can also change settings by clicking Subtitle Settings. Through the presentation, please feel free to send questions via the Q&A box. So you hover over the main screen, select the Q&A button. For me, that's actually in the little three-dot thing at the side, but it may be more visible to you. That should appear in your screen. You can send that at any time, and that lets anyone see the questions that you're asking. You can also go ahead and send anonymously if you'd prefer. And we'll probably go ahead and wait to look at questions until the end. Please do be sure to follow us on our social media. We try to keep people posted on information and events that HCT and the Midwest Trauma Informed Training Center are hosting, as well as kind of fun news and updates in the reproductive and sexual health space. A little bit more housekeeping. A link to complete an event evaluation will be sent to you. It'll be in the chat at the end of our talk, as well as by email following the training. We really do appreciate your feedback very much. So I know that those get repetitive and all the things, but we really do value them and read everyone. So please consider helping us help you better in the future by looking at that evaluation. You can also find other old presentations on our website and our YouTube channel, so please feel free to engage that way as well. And if you do have any technical difficulties during the presentation, my colleague Jen is here, and she will be checking the updates at hct.org email, so please feel free to contact her there, and she will get you all straightened out. So I am a nurse practitioner by background. I serve now as the Director of Health Strategy and Advancement at HCT, Healthcare Education and Training, the organization that's presenting this webinar today. And we here at HCT focus on improving reproductive and sexual health outcomes throughout the Midwest. We also focus on adolescent health and trauma-informed care. So in 2023, we opened MTITC, the Midwest Trauma-Informed Training Center, that I'll tell you a little bit more about in a moment. And I am honored to also serve as the director of MTITC. So clinically, I have worked as a women's health nurse practitioner, focusing on family planning and urogynecology, women's sexual health, and vulvovaginal disease. I still see patients 1 day a week, and that is through Path for You, which is Indiana's statewide contraceptive access project. So kind of all birth control all the time now. I always like to share, especially when I'm presenting on trauma-informed care topics, that I started my career as a forensic nurse examiner, as a certified sexual assault nurse. And so that really informed the way that trauma-informed care forms the backbone of all of my practice in patient care, in public health, really in the way that I view the world. So wanted to make sure to share that with you as we move forward. Let's see. I am a clinical training faculty for Organon, but that doesn't have bearing on today's talk. And funding for this webinar was provided by the Advancing Healthier Wisconsin Fund. So I said I would tell you a little bit about, a little more about MTITC, or the Midwest Trauma Informed Training Center. And really our goal is to transform what healthcare and human services look like by really making trauma-informed care the standard practice for all people and systems. So I'm love talking about this stuff, love working with people on this stuff. Please feel free to be in touch. My contact information is at the end, as well as a QR code to learn more about MTITC. And I would love to dive into any of this more with you at any time. All right. So, a couple of just level setting things as we jump into our talk today. First, it may go without saying, but anytime that we're talking about trauma, we are going to be talking about some potentially more difficult subjects today. So please do what you need to do to take care of yourself. As we go. Again, this will be recorded if you need to pause and come back to it, whatever that looks like for you. Also, just always want to acknowledge that there's always a range of experience and knowledge about trauma and trauma-informed care in the room anytime that I do a talk like this. So some of you may be sitting there saying this is totally new to me, and some of you may be sitting there saying I probably could give this talk, right? And all of that's fine. So we're going to go ahead and kind of start with some level setting, some basics and background. If you've heard me talk before, this will be familiar, but then we'll kind of go deeper in as we talk about how we can actually operationalize trauma-informed care and what that actually looks like for you to implement in your work setting. Of course, my background is as a provider, but hopefully we'll have examples that will touch on whatever your role is, whatever your life looks like within sexual and reproductive health. So I think without further ado, let's jump in. Okay, so we really can't talk about trauma-informed care without an understanding of what we mean when we talk about trauma. And trauma really can be defined in many, many ways. One definition that I like a lot is that it can be thought of as something that overwhelms an individual's ability to cope. I also rely heavily on the definition given by SAMHSA, the Substance Abuse and Mental Health Services Administration, and they say that trauma is something that results from an event or set of circumstances that is experienced by an individual as physically or emotionally harmful and that has lasting effects on the person's mental, physical, social, emotional, or spiritual well-being or functioning in the world. We know that that threat can be real or perceived, and of course there's lots and lots of other nuance. But perhaps the biggest piece, if you look back, sorry, I jumped myself too fast. You see the three bolded terms: events, experience, and effects. And perhaps the one that is the most important to me when we talk about this, I think, is that experience. So experience is key, meaning, as it says, it's the individual who decides if a given experience is traumatic or not. Said a different way, the same event can be experienced by one person as traumatic and not at all traumatic by another person, right? So one example that we can think of in a world of obstetrics and gynecology might be the experience of a C-section. So for one person, a C-section could be just one way a baby comes out, right? Maybe it's preferred, maybe not preferred, but just kind of not a big deal, right? For another, it might be really the birth that they want. It's the most empowering way for them to give birth, right? It's scheduled, it's planned, it's controlled, and really desired. But then for another, we can imagine that it could feel truly catastrophic, right? Perceived as a failure of their body, their self-image, what it means to them to be a parent, a woman, a mother, any of these things. And for that person, it might be perceived as a significant trauma, right? So again, same event, but experienced very differently by three different individuals in that case. Another example we could think about in kind of hopefully the world that you all are touching would be the experience of a new diagnosis of HIV, right? So maybe we have one patient who is aware of the existence of treatment options, they really understand U equals U, and they know people in their community who have lived robust and really long lives with HIV. So well, it doesn't mean new medical care and likely wasn't desired. They know how to manage it. They can cope, they feel supported, and it's not perceived as a trauma. We even hear stories about people who experience some relief because now they know they can manage it and not live in fear, right? Whereas then for others, we've certainly seen patients where this diagnosis is truly devastating and really is traumatic in their lives, okay? So hopefully that gives you a little bit of that perspective. Now, we know that trauma can be broken down into other categories. Some trauma is acute. So this is something maybe like a one-time natural disaster or a one-time sexual assault. Some trauma is chronic and or complex. We'll kind of group those together for today, although they are different concepts. But this could be things like witnessing or experiencing domestic violence, loving someone with a substance use disorder, experiencing human trafficking, that's often given as the quintessential example of complex trauma, or living unhoused. Now, I do also want to spend a few minutes on historical trauma. Historical trauma reflects systematic oppression of particular groups of people across generations. So this could include genocide, slavery, police brutality, forced relocation. I myself am the grandchild of Holocaust survivors, so certainly we feel this within my own family. So my point of sort of starting this conversation about trauma in this way is that we can see that trauma is more expansive than maybe what we think of as kind of big T trauma, what comes to mind immediately, and really is pretty universal, right? We all experience adversity in our lives, and typically, unfortunately, things that do supersede our ability to cope at times, okay? We can also recognize as we're having these discussions that while it is fairly universal, certain groups like women, children, communities of color, and the LGBTQ community are disproportionately affected. So I almost skipped this deeper dive and then thought, if we're talking about reproductive and sexual health, I kind of can't because it's so salient to the work that we do and what we're talking about today. So we have to know and acknowledge that our patients and clients bring a well-earned historical mistrust of the healthcare system into our interactions with them. And that, again, is especially true in our world of reproductive and sexual health. So in gynecology, there's several specific examples of historical trauma, starting with J. Marion Sims, who was considered the father of gynecology and even had this statue of him placed in New York City. It has since been removed. Dr. Sims invented the speculum, and he developed many surgical techniques that are still helpful in modern medicine, but he did this by experimenting on enslaved Black women. Now, you may have seen this painting before. This shows Dr. Sims and Anarcha, who is an enslaved woman who was just 17 years old when she had her first baby. And Dr. Sims performed over 30 non-consensual surgeries on her. He did not use anesthesia, even though it had recently become available. And at the time, it was really believed that Black women didn't feel pain as much as white women did. And in fact, that myth still persists today. It's well documented in the literature that Black people receive statistically less pain medication than white people do during hospitalizations and after surgeries. Now, this legacy of violence and historical and intergenerational trauma continues in our society, with more examples really than we can count. So we can think about Henrietta Lacks, who was a Black woman who in 1951 had her cells taken during cervical cancer treatment without her knowledge or consent for use in medical research. It produced the famous HeLa cell line that is still used today. There's also, of course, when we're thinking about family planning, the history of the pill, where clinical trials were done in the 1950s on Puerto Rican women without being told that they were in a trial or about the potential risks involved. Then we, of course, have our country's history of and ongoing instances of coerced or involuntary sterilization, to Tuskegee, which is perhaps the most commonly known example, where Black men were followed for 40 years, from 1932 to 1972, without treatment to see the progression of syphilis, and this was done without their consent, well after treatment for syphilis was available. And friends, I just always have to stop and think 1972 just isn't that long ago. Right? We're talking about within some of our lifetimes, or certainly our parents' lifetimes. And all of this has sown distrust in our system. So systems level trauma and historical trauma simply does enter our encounters every single day in healthcare and in life. So we talked about experiences and events. Now we're going to talk a little bit more about effects. Now, hopefully many of you have heard about the ACEs study. And if not, I always say this is your official invitation to learn more. So in 1998, Kaiser Permanente and the CDC did a landmark study. It included over 17,000 participants, so really a huge study. And it looked at 10 categories of adverse childhood experiences and found that living through these 10 ACEs can lead to or increase likelihood of a multitude of adverse health outcomes. Now, what they found was actually a dose-response relationship. So it didn't look at severity of abuse or neglect. It didn't look at frequency of these things happening. It just sort of said, did this happen to you? Yes, no. And the more ACEs a child experienced, the more likely they were to experience these negative health outcomes. Now, one important thing to keep in mind about this study is that the participants in this study were largely white, largely middle class, and overall highly educated. Now, a more recent Philadelphia ACE study focused on a more urban and more diverse population, and it really focused on community level adversity and how that could also impact health outcomes. And they found these additional 5 ACEs that are noted here in the blue circles. Hopefully they're big enough for you to see on your screen. And that included living in foster care, feeling discriminated against, experiencing bullying, witnessing violence, and adverse neighborhood experiences. We know that ACEs are incredibly common. From the original 10, 64% of people have at least one ACE, and 17% have 4 or more ACEs. Now, I want to be very, very clear that experiencing ACEs and other trauma or adversity does not mean absolutely that bad health outcomes will happen, right? We know people are resilient and they're buoyed by supportive and nurturing relationships and more, right? It is, again, about that kind of ability to cope and what you can do to help yourself cope. And that, of course, could be a whole talk on its own, talking about those supportive and nurturing factors that can help resilience. But ultimately, the higher one's ACE score, the more likely these poor outcomes may occur. So what kind of health outcomes are we talking about? Many, unfortunately. So we know that people who have experienced 4 or more ACEs are 12 times more likely to have attempted suicide, 7 times more likely to abuse alcohol, and 10 times more likely to have injected street drugs. Now, this also is linked to several of the top causes of pregnancy-associated deaths that are also linked to higher ACE scores, including accidental overdose, which is at this point the #1 cause of pregnancy-associated deaths. Now, it's not just things that could be considered coping mechanisms or mental health concerns that are associated with ACEs, because sometimes people say, well, that makes a lot of sense, right? Of course, if you experience trauma, you'll have more depression or more anxiety or things like that, or okay, it makes sense that they might use some of these less healthy coping mechanisms like using substances. But it's also things that make sort of less intuitive sense. We also see that ACEs are associated with higher rates of diabetes, cancer, heart disease, lung disease, even when we control for smoking, all of these things. There was even a study out of Wales that showed that the more ACEs a person experienced, the more likely they were to refuse the COVID vaccine or decline the COVID vaccine. So it has huge both personal and public health implications. Now, ACEs can have long-lasting impacts on our health, and one of the proposed mechanisms for this is through toxic stress. Now, we know that not all stress is bad. Some stress is healthy and positive because it prepares us to respond to temporary life challenges, right? Whether that is running a race, planning a wedding, starting a new job, or public speaking to esteemed colleagues, right? When these things occur, our stress response activates and then quickly returns to baseline. Now, more intense or longer lasting stressors can still be tolerable, as we've discussed, if we have support systems in our lives that are ready to help us cope. But if we don't have those supports, or if severe or frequent exposure to certain types of stress happen, then that can lead to a toxic effect on the brain and body, that sort of toxic stress category that you see on the side. Now, Nadine Burke-Harris, who is a physician, was California's first Surgeon General, has a great analogy for when positive or tolerable stress can become toxic that I want to share with you today. So I want you to imagine for me that you finished your work, you finished a stressful clinic day, and you decide you're going to unwind by taking a beautiful walk through the woods. You're out in the forest, smelling the smells, hearing the birds, seeing the skies, and all of a sudden you come upon this bear. Now, what kind of reaction does your body have in that moment when you're faced with that? You release a ton of hormones, right? We have adrenaline going and cortisol going that are going to help you either fight or flee from the bear, right? I'm going to be not successful at either of those things. Hopefully I'm going to choose freeze and hope the bear leaves me alone, right? But this is our fight, flight, or freeze response. And while you have that response, if it happens only once in a while, it's really protective. It's going to save your life, hopefully, in this scenario. It activates you enough so that you're able to respond appropriately to the bear. And now if you have fought or run from the bear or froze and the bear has left you alone, you're going to release all those hormones. You're going to leave the woods, go home to your family or your friends and say, oh my gosh, guess what happened today, right? Again, protective, saved your life, and you'll recover from that stress. But now I want you to imagine what happens if this bear follows you home and moves into your house with you. Now what kind of reaction do you have? What happens in our brains and in our bodies when we are faced with that type of really intolerable stress every single day? Our bodies just are not built to be in fight or flight all the time. So let's talk for a little bit about what actually happens in the brain when that bear is living in your house. We know that sustained activation of the body's stress response actually physically impacts many of the brain's functions. So the pathway in the brain that secretes hormones, the HPA, gets dysregulated. And the part of the brain that regulates memory and learning, the hippocampus, actually shrinks. The prefrontal cortex, the area of the brain that regulates thoughts and emotions, also shrinks. And the part of the brain that connects our emotions to many other brain abilities, like memory and learning and our senses, the amygdala, can actually get bigger. The amygdala, you may have heard of in the past, is referred to as our fear center, right? Now also, the part of the brain that takes in information from experiences and turns that into how we understand the relevance of those situations and how to respond appropriately begins to lose its ability to respond. Now we add in the stress hormones, cortisol and adrenaline from that chronically activated fight or flight response, along with that chronic stress, and you get inflammation, which contributes, as we know, to all manners of ill health. Now, these brain changes can actually alter the way that a person views the world and the way they function in the world. One example is how they build or struggle to build trust, right? And we can imagine quickly how an altered ability to build trust is going to be hard for us when we're working on providing health care, right? We need to build those connections and build that rapport very, very quickly. Now, since these changes can manifest in lowered ability to regulate behavior or control the expression of emotions, we have to think about how this is going to play out in our clinic environment. Have you ever had a patient or even a coworker respond in kind of an unexpected or unpredictable way to either a major or commonplace event? This behavior might appear impulsive or out of control. And that is something we have to keep in mind during our healthcare visits or when discussing STI exposure or perhaps an unplanned pregnancy, things like that. that scripts and norms, what we may expect as behavior, may be completely out the window. Which brings us to the concept of activators. So you may be familiar with this concept, as people often refer to it as triggers, and or being triggered, and there's sort of a movement to move away from that language towards this language of activators for two reasons. One, that the idea of being triggered has become pretty stigmatized, and two, one of my soapboxes is that we always have an opportunity to be intentional with our language, and trigger actually alludes to the firing of a weapon, right? Whereas activating means to induce increased activity, right? But we have a choice here to move away from the language of violence, and just, again, be really intentional in our language in these subtle ways. So an activator is something that reminds someone of a prior trauma or can initiate a flashback. It could be conscious or subconscious, and it can come in through all five senses, which is really interesting, right? We can think about maybe in a health center, a song that's playing on the radio. Maybe you're trying to use music to help decrease noise, right? To be protective of privacy, but the song that's playing maybe brings someone back to an event or traumatic experience. Or maybe it's something totally out of your control. Maybe it is the smell of a cologne that someone is wearing in your waiting room, right? So all five senses can be involved. We also know that when someone's activated, they may feel extreme distress that's similar to what was felt at the initial time of trauma, and their physical reaction could actually mimic what happened with that initial trauma. So that could be shaking, crying unexpectedly, could even be vomiting or dissociating, all kinds of things. Now, our patients may be unprepared for or unable to predict what that activator is. And because of how personalized each trauma and each person's activators are, providers just may not be able to predict what's going to initiate that flashback, anxiety, panic, dissociation, things like that. Now, of course, these can happen not only for our patients or clients, but they can also happen for us ourselves and for our staff. So understanding how common trauma is, we have to assume that the people we work with and that we ourselves may have experienced ACEs and carry certain traumas and activators into our interactions as well. And we know that one of our biggest and hardest jobs in healthcare is to figure out how to remain regulated in the presence of someone who is dysregulated, to figure out how we also can calm ourselves when we ourselves are activated in our work environment. Okay. Hopefully that is kind of a solid background on kind of some trauma concepts. Sorry, I'm going to pause for a drink. So that we can now dive in to what we can do about it. Let's talk about trauma-informed care. So trauma-informed care is a whole person approach to healthcare that acknowledges the impact of trauma on health and is inherently patient-centered. It acknowledges that a patient's life experience will impact their perspectives and priorities when engaging with the healthcare system, and that awareness of these perspectives has the potential to improve patient engagement, treatment adherence, and health outcomes. Now, trauma-informed care is not the same as providing trauma services like treating a broken leg or doing intensive trauma therapy, so no one is asking that of you. And also, it's really important to acknowledge that disclosure of past trauma is not necessary to provide trauma-informed care. And we'll talk more about that in a few minutes. We utilize the 4 R's, again created by SAMHSA, that states that a trauma-informed approach is one that realizes the widespread impact of trauma and understands potential paths to recovery. It recognizes the signs and symptoms of trauma in clients, families, and others involved in the system. It responds by fully integrating that knowledge into our policies, procedures, and practices, and it seeks to actively resist re-traumatization, or I would argue in the healthcare context, also seeks to avoid the creation of new trauma, because we know that healthcare itself can be traumatic for folks. So this should really guide both the individual and organizational approach to care. If I were going to ask you to take one thing away from this talk today, it would be that trauma-informed care is really a paradigm shift. And what I mean by that is the shift in looking at someone and thinking, what's wrong with you? What's wrong with this person? To looking at that person and thinking, what happened to you? What happened to the person in front of me? And I like this slide because I think that, trauma-informed care is a really interesting academic concept. I did my doctoral dissertation on trauma concepts. I think it's fascinating, but it doesn't help us if we can't operationalize it, if we can't use it to impact our practice and to help our patients. So again, at its core, it is that paradigm shift. We also talked a bit about how we don't actually need a disclosure of trauma to provide trauma-informed care. And the way that I think about that is that we know how sort of ubiquitous and common trauma is, and we have a desire, again, to never re-traumatize someone or create new trauma in our care if we can possibly help it. So we're going to utilize, for a trauma-informed approach, a universal precautions model. And we can think about this the same way that we think about bloodborne pathogens, right? We don't wait for someone's labs to come back to put our gloves on. We just assume that anyone we might be interacting with or could be caring for might have a bloodborne illness, and we treat all patients like this universally, right? It is not enough to use a trauma-informed approach only with some special subsets of our patients or clients, like those we know have a history of sexual assault, for example, or for someone's first pelvic exam, right? Again, it's that paradigm shift from an attitude of judgment to one of curiosity and compassion, right? No one owes us a disclosure, and everyone deserves this care. Now, of course, I want to be clear that it is true that I will provide the best care the more I know about my patients, right? It is helpful if the more they tell me about themselves, right, including their history. But they still don't owe me that disclosure. And there are also some circumstances, perhaps you've worked in multiple different environments, where a disclosure of a past trauma may be less relevant or really just not somewhere they want to go that day, right? I think about the difference if I'm in an environment where I am someone's primary care provider and I'm building an ongoing relationship, month after month and year after year, where we really are building trust and getting to know each other, versus if I'm in more of a one-and-done clinic setting where someone might be coming in just because they are itching and they need their itch to stop, right? Of course, again, the more I know, the better, but I can still do the most gentle speculum exam of my life. I can still provide them choices at every corner, right, without knowing anything about their history, okay? So hopefully that kind of explains that piece. And then again, as we started to discuss, this really isn't just about our patients. We know that likely our colleagues and coworkers also have their own histories. And while less relevant for today, I also extend that to our families and friends because, again, my second soapbox of the day is if we all move through our lives and our worlds and our interactions with this type of perspective and approach, I think we really would heal and improve our entire communities. So family and friends as well. And then finally, a quick note about you yourself. Not only is it possible that you yourself as a provider, a healthcare worker, have experienced this type of, or some type of trauma yourself, but also there's a concept called vicarious trauma or secondary trauma, which basically means that as we as care providers engage in empathic ways with other people's stories of trauma, that our worldview can be changed and that we ourselves can experience some of those brain changes and physical changes that people experience when they are exposed to trauma. So again, I love talking about vicarious trauma. If you ever want to talk about a talk just on that, I'm delighted to talk about that. There's so much more to say, but it's something important for us to be aware of, kind of this potential for a double dose of traumatic impact, both our own histories and the way that we're engaging with patients that we care for. Okay. So practicing trauma-informed care requires an intentional approach in our interactions, again, with ourselves, with others, and with the systems in which we live and work. So Sam's, you see the 4 R's on the, hopefully that's the left-hand side for you, it is for me, and the 6 key principles on the other side of the screen. So I want to sort of walk through these key principles and talk about some ways that we can, again, operationalize this in our care. So the first principle is that of safety. Now we know that after someone experiences a trauma, safety can be difficult to be regained. When we're talking about this in practice, we have to think both about physical and psychological safety. Now that is safety both for the people that we serve and for staff. Let's start with talking about emotional safety, and this can look a lot of ways. One of the keys is to give patients power and control whenever possible. We can do that by listening, by not interrupting. We know there's a study that talks about that in healthcare we generally interrupt our patients within 11 seconds of them opening their mouths. So we want to try to be fully present. We want to pay attention to their nonverbal cues. We want to avoid invasive questions. And I know that is a little bit ridiculous to say when we're talking about reproductive and sexual health, where literally all we're doing is invasive questions, right? And so for us, I sort of reframe this as only asking questions that serve a purpose, right? If we are able to not ask questions just because we're clicking a box, but really think about, will this impact my plan of care? Will this impact what's happening today or moving forward? For physical safety, we want to think about the environment that someone is in even before they come into our space. Is our parking lot well lit? Or might someone be coming inside already stressed from a walk through a dark outdoor space or something like that? It's also important that we remember that safety can be defined differently for different people. So one kind of clear example is the presence of an armed security guard in your facility. For some people, this may make them feel really protected and be really reassuring, right? But for others, it may feel very threatening, depending on people's personal or community experiences with policing. So just a reminder that people's experiences will always impact how they interpret what's around them, and there isn't always one solid, clear, right answer. The next principle is that of trust and transparency. So we want to be providing clarity and honest answers everywhere we can. And that includes that it's okay if you don't know the answer to something, right? Hopefully that's something we've all heard before, but it bears repeating, that it's okay if we don't know the answer and better to be honest about that. Explaining processes helps our patients know what to expect next. And then you want to also follow through on what you said you would do. We talked a little bit about asking personal history questions, especially around that sexual history taking. It can always help to explain upfront why you're asking, right? It's very different if someone just hears like, hey, what kind of sex do you have, right? In this way where maybe they think that it's sort of a intrusive or over personal question. Whereas if we set it up as, hey, we're going to ask some questions about your personal sexual behaviors, because that's going to help us know where we need to test, right? If we're talking about STI testing, or it's going to help us assess your risk or other things, right? Setting that up can make a very personal question at least understood, right? And that can help. Ideally, it also means that organizational decisions are made with transparency and shared among staff and throughout an organization as well, working on team dynamics that help us in turn provide trauma-informed care to our patients is really served by having a trauma-informed work environment as well. The next concept is around peer support. Peer support and mutual self-help are really important for establishing safety and hope, building trust, and enhancing collaboration. So you see how all these principles kind of weave themselves together. So peers are those who have also survived a similar trauma. So we can think about support groups for infertility or infant loss or sexual assault or domestic violence survivors. Peers can really use their stories and lived experience to help promote healing. Another example of peer support that is common in public health might be peer counseling in substance use treatment or in HIV care. It's also important that we think about this one for our teams. How do we support each other at work? Do we have a buddy that we can debrief with after a hard day? Is your supervisor accessible and supportive? Do you have time set aside for real team meetings? Is that time paid and built in, or is it on your own time? Is it expected and encouraged? Is it viewed as a sign of health and strength? Or might it be viewed as a weakness in your environment or deprioritized when other learning needs or workplace requirements come up? So lots of things to think about that I'll just sort of like drop there for you to think about moving forward. Next is collaboration. So developing partnership between staff and those they work with is really important. Also leveling power differences between you and the people you care for at every opportunity. We know that there are power dynamics that are inherent in what we do. They don't call it white coat syndrome for nothing, right? Our patients come in needing something from us, and so we can serve as gatekeepers. Our titles, our roles, our education, it all comes with power. And we need to acknowledge that no matter our expertise or our role, whatever power and expertise we bring in, our patients are really the experts on their own bodies, their past experiences, their current experiences, and their priorities and goals. Okay? So we can think of this as shared decision making, but it can also be framed perhaps better as patient-led decision making, because something that doesn't work for them is not going to work, even if on paper it looks like the best option. Okay. Next, we can talk about empowerment and choice. The patient should be given choice and control at every step. I've said that before. We want to ask their preferences and offer enough detail to inform decision making. We should try to recognize and build on the strengths of the individual. And we know that empowerment relies on our belief that the people we work with are resilient, right? And the fact that people and communities can heal and promote recovery from trauma. So we can do all this by, again, utilizing shared or patient-led decision-making, giving choices, goal setting in a way that is developed, where plan of action is developed together. We also want to make sure that we are doing our best to frame things in a positive and affirming way. So rather than, why'd you let that prescription lapse? Or what did you think would happen when you had unprotected sex, right? Or why are you coming in so late to prenatal care? We could instead say, I'm so glad that you came in today, and I'm so glad that you're here now. Let's get on track together, right? The last thing that we'll talk about here is people's context in the world, and this includes recognizing places where historical trauma may play a role in people's mistrust of healthcare or medication. It also means that we are going to work on identifying and working through our own personally held biases. For example, who should or shouldn't become pregnant, or how many times should someone become pregnant? Are there types of people who are more likely to need or who are more likely to offer PrEP to? We need to think through all of that and kind of own our own stuff, okay? Using humility and always working on knowing more and doing better is key in here. Now I want to move forward to talk a little bit more about trauma-informed care specifically in reproductive and sexual health. So we looked at some general health outcomes, but these are some that are more specifically sexual and reproductive health related that are also associated with higher ACE scores. In addition to what's listed here, ACEs are also associated with intimate partner violence, both victimization and perpetration, pelvic pain, and increased discomfort during pelvic exams. I also want to acknowledge that sometimes these can be among our challenging clients, right? Maybe it's frequent flyers or people where we just feel like our best efforts to support and help and guide are falling short. And it's natural and it's okay that this can feel frustrating. If you feel like you've gone above and beyond with a patient and you've given of yourself and your time, and then they sort of turn around and put themselves back in that same position, right? But these are the moments where practicing that paradigm shift matters the most. Not what's wrong with you, but what happened to you. Okay. One important piece of reproductive and sexual health is family planning and contraceptive counseling. So I want to take a moment to talk about the concept of reproductive justice and discuss contraceptive counseling. So, whoops, sorry, too many clicks. I got click happy. There we go. So in my mind, we can't provide trauma-informed contraceptive counseling and care without a commitment to reproductive justice. The reproductive justice framework states that it is a human right to maintain personal bodily autonomy, to have children, to not have children, and to parent the children we have in safe and sustainable communities. Now, this framework was developed in 1994 by women of color, and it highlights the idea that decisions about family planning are not made in isolation. Most importantly, that all decisions about bodily autonomy are supported. So ultimately what this means in practice is that no decision is deemed less than another. So one person can decide on condoms as their contraceptive choice and another can want an IUD, and these choices should be supported equally and in the same way. Now, talking a little bit more about contraceptive counseling and models of contraceptive counseling, again, just so briefly because we don't have so much time together. In the early 2000s, there was excitement about LARCs that raised concerns about a lack of access to these methods and an increase in funding for these methods, which is great, right? Major health organizations, including the WHO, the CDC, ACOG, and the AAP, recommended what we called a tiered effectiveness approach to counseling. And many of us may have been trained in this model, right, that sort of promoted LARCs and focused on what was most likely to decrease unintended pregnancy. Now, from a medical model, this makes sense, right? We are unlikely to suggest less effective medication for cancer treatment or management of diabetes and all these things. But we have to acknowledge that reproductive health and family planning is different in some ways. And when we think about tiered counseling, it really does sort of imply that one tier is best, and someone may feel guilty or coerced or unsupported in choosing a lower tier method. It lacks that patient-centered focus on patients' preferences and goals and values and that individualized counseling. So LARC-first counseling can also be complicated by the fact that removal requires, at least in most cases, a provider. And that can be harder to access or can increase the risk of coercion compared to methods that a patient can discontinue themselves. Or it can set up a dynamic where patients need to sort of justify using a worse method instead of leading the decision-making process. So trauma-informed and reproductive justice-focused contraceptive counseling really views all methods as equal and patients' preferences as the priority. You know the medicine, but they know their own lives and needs, and the best contraceptive method truly is the one that works best for them. Also, quickly, I want to mention, we often talk about women's health. I mentioned I'm a women's health nurse practitioner, and many of us may work in women's centers or women's towers or have certain days that are women's clinic. So think about what would happen in your workplace if one of the people in this couple came up to the desk and said they wanted birth control. In some settings, I think that the response they might get is, okay, bring your girlfriend back, we'll talk to her. But in this scenario, one of these guys is trans. Can you tell which one? Of course you can't, right? And that's why it's so important that we approach people with an open, curious, non-judgmental mind and work against our internal biases. Also think about how hard it might be to come to a women's center or schedule at a women's clinic for these people, right? We put up so many unintentional barriers, and with intentionality, we can work against this. Okay, so you may be familiar with these folks. Just quickly, this is Biff and Tristan. They gave permission to share their story. Biff is on the left and Tristan is on the right. Biff is cis and Tristan is trans, and they gave birth, Tristan gave birth to Biff's biological child in 2017, and it made international news. So again, just a reminder that if a masculine presenting person approaches your counter and wants to talk about contraceptive care, it's the same respectful conversation that we would have with any patient. Our trans and non-binary patients absolutely deserve this care as well. So next I want to talk a little bit about the pelvic exam. There are so many potentially activating things involved in a pelvic exam, right? We can look at the vulnerable physical position on our backs, feet sort of held in footrests. We are undressed, right? And not only undressed, and I don't know many people who are their most comfortable when they're naked, but also our genitals are exposed, right? This is about as vulnerable as you can get. The clinician, no matter how good we are at our jobs, is very close to a stranger. And again, we already talked about those inherent power dynamics. And then there's the exam itself, right? Which, while it shouldn't be painful, is likely uncomfortable. I want to stop for a second and note some of the word choices again that I've used here. So thinking about drape versus sheet, an exam table, not an exam bed, right? We're really working on getting any language of sexuality or of the bedroom out of this scenario, okay? Because we have to just be honest that things that happen in the pelvic exam can closely mimic things that happen in people's personal, intimate lives, right? Even though it makes me very uncomfortable to label something as an intimate exam, right? That is language that's being used now, right? And there's truth to it. So while this is very normal for us and something we are doing maybe dozens of times a day, it is anything but normal or anything but routine for our patients. So we just have to honor that and think about that, okay? And do everything that we can to sort of work against that. We can also think of plenty of other activators in that space, including things like open your legs wide or just relax. Just, again, the presence of someone standing over someone while they are in that supine position, and those power imbalances. So we want to think about strategies for that. Again, never saying open your legs, but rather thinking about, okay, maybe bring your knees to meet my hands, right? Then I'm certainly never pushing someone's legs apart. They are the one with the agency, right? Thinking about the way that we language and work through all of that. And again, I wish we had more time and we could go into that further. We have to think about the context. And Jen, can you just throw me a confirmation? We are done at 1 hour, right? Not 75 minutes?
It is 75 minutes.
It's 75 minutes! That's so great. Okay, we have a little more time. That's glorious. Thank you. Great. Cool. We'll still keep moving quickly, but a little less frenetic. So I want to talk about context when trauma is linked to healthcare. And this can be for when trauma is caused by the healthcare itself. We talked about the C-section. We know that between 25 and 34% of women report childbirth as being a traumatic experience, right? And then there's also proximity, right? The act of seeking care that is secondary to a trauma, right? So we often think about that maybe someone who's coming in to the ER after a car accident, or again, I started my career as a sexual assault nurse examiner, so that kind of healthcare sought immediately following a trauma. But we can also think about places where these lines can be a little blurry for someone, right? There are any number of things in reproductive and sexual health scenarios that can be traumatic for folks. So we can think about an exposure to an STI. Again, we talked about that diagnosis of HIV, learning of a partner's infidelity, learning about undesired pregnancy, right? There are any number of things that could bring healthcare into that traumatic sort of experience. And we want to do as much as we can to provide this excellent trauma-informed care because we don't want patients to be sort of activated by the act of seeking healthcare in the future, right? Whether that is seeking sexual and reproductive healthcare or seeking healthcare globally. This can have significant impacts on people's ability to engage with the healthcare system moving forward. We, again, want to be prepared for a range of responses. Again, that could be managing anger, dissociation, difficulty making decisions. We want to, again, give patients as much power, choice, and control as humanly possible. So some things in our environment could be, how are we going to do testing? Is that going to be through urine? Is that a self-swab? Is it an exam? Now, is the exam an opportunity for education and healing, right? Can you have a mirror in your office so that you are really teaching someone about their body during an exam, or being reassured that things are normal, right? Is it necessary to do an exam for their presenting concern, right? Let's make sure we're not just moving through the motions. Could it be deferred? Could the exam be performed in a different position? Could we use the footrest, the table at the end of the exam table, right? The pullout, instead of using the footrests, right? Could the patient self-insert their speculum? Is that something you could walk them through, right? What are the ways that we can empower and offer choices? Could we offer expedited partner treatment? Can we ensure that our patients know what is being tested for and what isn't? Certainly, we've all had patients come in and say, like, oh no, my partner said they were tested for everything. And you're like, oh, tell me a little more about that. And they're like, oh yeah, well, I know they went in and they peed in a cup. That is a great start, but we know that means not everything, right? And that's not because they are silly or stupid, right? That is because we sometimes don't do a good enough job of getting that message across effectively and explaining what's going on. We also, of course, have to think about making sure that people are empowered and understand the window periods, right? What is this testing reflective of, and when should they come back? Often people come in because they had something happen to them this past weekend that they're worried about. And while I'm so proud that they're coming in and being proactive about their health, I need for them to understand that their results likely aren't going to show something from what happened, 2 or 3 days ago. Again, we want to make sure that we're doing that true, non-coercive, non-directive contraceptive counseling. Also, I've lost track of how many soapboxes today. I mentioned briefly that people sometimes face coercion around LARC removal. It is so important that if someone comes in and wants the LARC out, that it comes out, right? Now, that is not to say that you don't have a really good conversation about, changing length of efficacy, right? Maybe they say, I have to get this out at 3 years, and you can now tell them, no, the FDA just approved the implant for 5 years, yay, or the IUDs that also keep changing, right? Give them that information, right? Don't remove it blindly. Similarly, if they're having side effects, can you talk with them about their side effects and give them alternatives to try? But at the end of the day, if they want it out for any reason or no reason at all, they are the ones that have agency over their bodies. So there's an extra soapbox for you. Also, again, we talked about this a little bit with the pelvic exam slide, but there's really nothing trauma-informed about meeting a patient when they're unclothed, right? Now, it is the reality of many of our clinical environments. I worked in a place where I had an overbooked Q10-minute schedule, right? Those patients, unfortunately, were already kind of under the paper under the paper when I came into the room. But if you are in a decision making or power position where you can influence policy or clinic flow, what a beautiful thing to advocate for, that you might be able to meet or educate or interview your patients with their clothes on. Okay, let's talk a bit about informed consent. So, gosh, I wish we were in person for so many reasons, but one of them is kind of to co-create a definition of consent, and I always love to hear what people have to say, but for time and since I'm talking to the void, I'll just pop up some of the things that I always think about. So consent is unmistakable, often verbal, uncoerced, freely given, reversible, and specific. I also always like to emphasize that the absence of a no is not a yes. We actually want to get affirmative consent. And I want to read you a quote from a wonderful nurse midwife named Stephanie Tillman, who said that consent is a clear dialogue between individuals to engage in a specific activity. Expectations for consent to intimate examinations in healthcare should be equal to, if not exceed, expectations for intimate interactions in society. And so what this always makes me think of is, when we talk about consent, what are we normally talking about? One, we think about informed consent for medical care. And two, we think about sex, right? We talk about consent for sex all the time, or hopefully we do. And, I often think about that we would know if someone was having sex and they said to their partner, no, stop, wait a minute, and that partner responded to that no or stop with just a sec, I'm almost done, we would know when we're talking about sex that has crossed a line into assault and that is not acceptable. And yet, I think we see that in healthcare a lot, where someone says, stop, wait, and we say, just a sec, I'm almost done, right? And I don't think that anyone is doing that out of an intention to harm our patients or with a desire to commit assault, right? That's not why we got into this field. I think we're doing it because that's the service they came in for, right? They said they really wanted their pap smear done, or they really want an IUD as their contraceptive method. But really, the minute that someone says no or stop, it is our responsibility to stop, because continuing on is assault. Again, as Stephanie Tillman says, the expectation for consent in intimate examinations should be equal to, if not exceed, expectations for intimate interactions in society. Okay? And we can talk more about strategies to navigate that at the end. If I don't, yell at me about it and we'll talk more. So some other things to think about around informed consent are that we know that unintentional misunderstandings can happen for 1,000 reasons, including, as we've talked about, that what's routine for us is anything but routine for our patients. Also, because of the way that the brain processes during trauma or high stress environments. Also, because of biological needs. If your patient is hungry, is tired, is worried because you were running behind and they're worried about getting home to their kids or to work on time or whatever it is, right? We know that things can be perceived as assaultive or crossing a line if someone does not believe that they have given consent and given consent freely. So we have to really make sure that this is clear. When I talk about context, of course, I mean that sort of historical trauma that we've discussed. Coercion, again, another quote from Stephanie Tillman says, in healthcare settings, actions that would be considered coercion or assault in social settings are often erroneously labeled as clinically or medical legally rational. So again, a couple ways that we can think about this. I think that coercion can range from sort of a loaded or directed counseling, like I'd prefer to do X because in my experience, right, or what I would want for my loved one is, and I think honestly people ask us, well, what would you do? Often, right? We're often not the ones like offering that up. People ask. But I think that the concern is that even a gentle or well-intentioned recommendation can then make someone feel uncomfortable about hurting our feelings or not agreeing with us if they want to go a different direction, right? There's also more kind of overt coercion, which is like, I hear you declining, but what I want to emphasize is, right? Which is one of the reasons that explaining the full range of risks and benefits should really happen before seeking consent, because once someone has declined something, explaining the risks to declination after that can be coercive. And then again, to that truly can be defined as assault, that just another second after being asked to stop. So I said I would mention a strategy to work with that. And one of the things that I like a lot is to sort of have a discussion about two different words. So we can say, if you say stop or if you say pause, I'm going to stop what I'm doing completely, and we're going to check in. Do you have a question? Do you just need a break? What else, what needs to happen before we can move forward with this or decide that you're done, okay? But if you say out, right? For me, I use out because I'm usually talking about a speculum or something that's in the vagina, right? For your context, it may be different. But out, or you can say hippopotamus, or you can say if you clap your hands, if you think that it may be difficult for a patient to verbalize, right? But some kind of a more unique word. If you say out, I will completely stop what I'm doing, take the speculum out, all the things, no questions asked. And I just want to make sure that you understand that means that we may not finish the service that you were requesting today, right? And I think that can alleviate some of our fear around like, oh, it's so close, we're going to get this done, and really giving that power back to them completely. So that's one of the strategies that I like to use. And then again, I just always want to mention that a true informed consent process has to allow for both a no and a yes, that informed declination is as valid as informed consent. My note about language quickly is just thinking about the difference in the power dynamic and belief about agency and autonomy between the word that someone declines something and that someone refuses something. So there's my 89th soapbox of the day. All right, so just to kind of wrap up quickly, we know that trauma-informed care is not a checklist. It's not like, all right, here we're gonna move through these motions and boom, we're trauma-informed. So I wanted to, again, leave you with some additional strategies to operationalize this. So one, again, is explaining steps, equipment, etc. before beginning each step. What to expect, the rationale, the risks, benefits, and alternatives, which looks an awful lot like a good informed consent process. This calls on those principles of safety and trust and transparency. Then place and space, we want to think about, again, that physical and emotional safety. Try to not stand between the patient and the door so they always feel like they have an exit, things like that. Other, very basic things to promote comfort, like lubricant and can things be warmed, and an appropriately sized speculum, things like that. Also, can we have a support person in the room? Can our patients use distraction, right? Like music or playing on their phone. I used to feel really offended when someone would have their phone out early in my practice, and now I usually talk about it and just say hey, if it's okay, I'd love you to put it away for this part while we're having this conversation, but if you want to be on your phone while we're doing the exam, if that helps you, then that's awesome by me, right? Also, if we are talking to someone on the phone, is this a good time, right? Are they able to talk? Do they have privacy? Permission. We can't assume the right to people's stories. They don't owe us a disclosure. We have to earn their trust. We also can't assume the right to people's bodies, right? Or even their time. One real subtle language change that you can try, instead of, okay, I'm about to begin the exam, which is great that we're giving them upfront acknowledgement. We're not just jumping in, right? I think back in the day, that was a battle we were fighting, to even say you're going to feel me touch before touching someone, right? I think that's fairly standard now. But what about going a step beyond that? And instead of saying, okay, I'm going to start the exam, you're going to feel me touch, if you said, will you let me know when you're ready to begin the exam, right? Or with your permission, I'll begin. Let me know when you're ready. what a huge difference does that make? Okay. Again, empowerment, we've talked about. How can we really reassure someone that even if they have negative feelings about what brought them into clinic, or if they're feeling some shame, because we have so much shame around sexual health and other things, right? Again, that could be its own talk. But what if we spent time focusing on you're taking really good care of yourself right now, right? And I'm so glad that you came in to talk about it today, okay? Now, going against a little bit of what I said before, we also have to acknowledge patients' preferences in their communication desires. So, do they want all of the information, or do they prefer to just have the minimum needed? You know, I can explain every step of what I'm doing, or I can help you with distraction by talking about your kids and pets, or helping you do breathing exercises, or you can do your own and just, again, go inside and do your own kind of calming and regulation. I won't know if I don't ask what's going to be best for them. Also making sure that we're presenting any aftercare instructions in writing, because in high stress environments, our brains just don't process and retain very well. So making sure that they are leaving with something they can review, okay? And then finally, we talked about that trust is one of the mental schemas that is specifically altered by trauma, and we have to keep that in mind when we're approaching people and building relationships. And as you've heard me say before, going back to that shared decision-making or patient-led decision-making framework, that while we are the experts of what we do, we have to trust that our patients are the experts of their own lives and circumstances. So that brings us to the end. I have a bunch of references here. I'd love to do 5 minutes for questions. I also want to leave you with my contact information. Again, I'm happy to talk about this anytime. That QR code on that page is the QR code to sign up for the Midwest Trauma Informed Training Center mailing list to stay abreast of our offerings. And I also have a QR code for our evaluation. And again, we really appreciate you sharing feedback with us. And I think Jen did drop that in the chat for you.
All right. Thank you so much, Cara. Such good information. As a reminder, if you want to drop a question in the Q&A or the chat, feel free. We do have one question, and I know you've touched on it, but just to kind of get us started is, what strategies can providers use to reflect on their own reactions so they don't unintentionally undermine trauma-informed care?
Yeah, such a good question. So, I mean, I think part of it is just a real honest assessment of what comes up for you. When do you have to sort of fix your face, right? What today did you think, ooh, I'm not sure how I would do in that circumstance, right? I will always advocate for, thinking about having a partner to reflect on these things with, whether that is a supervisor, a colleague, a counselor, a therapist of your own, right? To really work through some of this. If those things are not for you, writing can actually be a really brilliant way to work through some of your own feelings on things. But just remembering that our role is non-judgment. Our role is supporting people where they are in their lives. Yeah.
Okay, and then a follow-up to that, because you also mentioned early in your practice if someone was on their phone and, kind of how you felt about that. How can you incorporate trauma-informed care practices, knowing that sometimes there's a time limit in how long you can spend with a patient?
Yeah, that's such a good question. So, a big one is really that transparency piece, right? It's expectation setting, and it's honesty. So, we all have had the experience of someone coming in and having a mile-long list of things they want to address that day, and just knowing that we can't. And so, one of the things that I really like to do is to say, like, can you tell me what is your priority for the day, right? And one that's helping them sort of level set and say, like, that's so great. I want to make sure we give that the time and attention it deserves. Gosh, everything else that you're bringing up, also really matters to me and really matters to your health. But I don't want to like give short shrift to any of them. So I'm going to ask that you make a separate appointment to talk about X, Y, or Z so we can really get into that. And sometimes it happens that, you know, their priority is not my priority medically. And so we also have to, again, just have a transparent conversation about that. Because sometimes they're like, yeah, I've had this breast lump for, 6 months and, I don't feel that concerned about it. But I'm really concerned that today I'm itching, right? And I'm like, I really get that. You are uncomfortable today. And I really can't not address the breast lump today. So we're going to kind of work through that together.
Great, thank you. It looks like we don't have any other questions. Kara's information is on the screen. I know she meant it when she said it. If you have any questions, don't hesitate to reach out to her. We'll make sure to send out a link to the evaluation, although it is up on the Kara's screen right now. And I dropped the link into the chat. And along with that, we will send a recording to today's webinar. So, and it will show you kind of where all of our other recordings are. So feel free to kind of play around on our YouTube channel. And I appreciate it again, Cara. I hope everyone has a great afternoon.
Thanks so much, everyone. Take care.